Hello, welcome to my channel. So today we are going to be talking about how I made theory. So this will be our part 1. This will be our I made theory part 2. So part 2. So this is the episode 1. Okay. Episode 1, part 2. So starting with question 6. So we are going to go through question 6 to 10. Okay, so let's start. Question 6 says, what is in brackets Jones criteria for rheumatic fever? Oh, most people just know it as the Jones criteria. So Jones criteria is what we call the major criteria and the minor criteria. Okay, so starting with the major criteria, we have the mnemonic, which is cases. So C A S E S, that's cases. That is the mnemonic. So C is for carditis. Okay, that's C. Then A is for arthritis, but specifically there is a progressive migratory polyarthritis. Then S is for Syndenium scoria. That's S for Syndenium scoria. Then E for erythema magnetum. Then S for subcutaneous nodules. That is cases. We are done with cases. Then for the minor criteria, so for the minor criteria, the mnemonic is FRAP. So F-R-A-P. Okay, then F is fever. The first F is fever. R is raised ESR or CRP. Then we have arthralgia in the absence of polyarthritis. Then we have prolonged PRI interval. Then we have a previous rheumatic fever. That is the Duckett Jones criteria. Okay, so if you are watching this, then before we proceed to the next station, I want you to write down. So write down the diagnosis. So how do you make a diagnosis? So in short, there is what we call the major criteria. How many measures can you use to make a diagnosis of rheumatic fever? Then how many minor do you need to make a diagnosis of rheumatic fever? Or how many major plus minor criteria are you supposed to use to make a diagnosis of rheumatic fever? That's what I'm asking. So you can just drop the answer in the comment section so that we proceed. Okay, then question 7. So question 7 says, a 40-year-old man presents to accident in emergency unit with shortness of breath of 5 months duration, which initially started on exertion, but lately gets breathless even at rest. Then he further says he is unable to lie flat. And has developed, so this is not supposed to be there, and has developed swelling of his feet. He was once found with high blood pressure, for which he stopped the medication. He says he enjoys smoking and as well as taking alcohol for a long time now. His father died of a sudden death 5 years ago, and the cause of death was not established. So A, give 4 other signs we would list on the history. Then list down 4 signs we'd look for in the physical examination of this patient. Then what is the working diagnosis? Then which investigations would be relevant in this patient? Outline the principles of management of this patient. Then what advice will you give to this patient regarding his health? Okay, regarding his health. So starting with the answers, so give 4 other symptoms to a list in the history. So this is a 40-year-old man who was presented to our A&D unit with shortness of breath of 5 months duration, which initially started on exertion but rarely gets breathless even at rest. He further says he is unable to lie flat. Then he has also swelling and has developed swelling of his feet, and he was once found with high blood pressure, for which he stopped the medication. He says he enjoys smoking as well as taking alcohol for a long time now. So his father died of a sudden death. So further symptoms to elicit, you can elicit for any cough, fainting, dizziness, syncope, is fatigability, PND, chest pains, palpitations, even orthopnea. Okay, but for orthopnea, even if you don't put, I think it has been highlighted in the part which says he is unable to lie flat. Okay, so we're just going to skip it. Okay, but these ones we have mentioned here are not present there, so they are a very good way to go. Okay, so for PND, for those who don't know, it is paroxysmal nocturnal dyspnea. Okay, that's PND, the paroxysmal nocturnal dyspnea. Okay, then list down four signs we look for in the physical examination. So for the 4 signs we look for in the physical examination, okay, so we have divided our examination into on inspection. So on inspection, there will be tachypnea and signs of respiratory distress such as nasal flaring, subcostal recessions, intercostal recessions, tracheal tag, including use of accessory muscles of respiration. There will be jugular venous distension, frequently which is present and engorged, and there will be engorged neck veins. Then skin may be diaphoretic or cold, gray, and cyanotic. Then there will be lower extremities. Then in the lower extremity, there will be edema, which may also be noted, especially in the subaqueous process. So we are done on inspection. Then on palpation, there will be an apical pulse, frequently which is dispersed laterally. Then there will be a pulse as alternance, so it will be alternating weak and strong pulse, which is indicative of depressed left ventricle function. Then on auscultation, there will be a wheezing or rails or crackles, maybe head or lung auscultation. If it has even complicated to a pulmonary edema or there is pulmonary congestion, and there may be bilateral basal downers if at all the patient presents with, depending on the stage the patient has come in. Okay, then for cardiac auscultation, it may review an aortic or mitral valvular abnormalities. There may be S3 or S4, murmur. So these are some of the things we're going to find, and there may be tachycardia. Okay, so this is how you go about writing the signs you drew for the physical examination. So instead of just listing them, you can list them as on inspection, on palpation, and on auscultation. Okay, then moving on. So what is the working diagnosis? The working diagnosis is CCF, likely due to uncontrolled STN, smoking, alcohol use, and even stopping the medication, and possible families to what disease as well. These are the this will be our working diagnosis. Then not further investigation and do this patient. So labs, we can do U&Ds, creatinine, lipid profile, LFTs, and liver enzymes. Then imaging, can do chest X-ray, echo, ECG, CT scan, and then abdominal ultrasound. Okay, but remember, investigations, sometimes they might ask you to put investigations and put rationale. So don't just put any. If you have say something, remember the rationale that you are going to put there. Okay, then outline the principles of management for this patient. So one, you can do our general measures where we stabilize the patient to give supplemental O2 therapy. We identify and treat the precipitating factors and underlying cause. So 2, we are going to control the congestive state, which is also known as reduced preload. And how do we do reduced preload? We use diuretics, but more specific, we use the spironolactone, which is cardioprotective. So you can even use, depending on how the patient has come, so you can even use even furosemide should be used depending on how the patient has come. Okay, the spironolactone, even you can add furosemide. Okay, that is how you go about reducing the preload. Okay, then the 3 principle is to improve myocardial contractility. So depending on, again, using your ejection fraction, if it's reduced, then you can give your digoxin and follow the digoxin parameters that has been employed. There's also data on digoxin use. There's a lot of guideline on how to use digoxin. Okay, then 4, we have to prevent decrease in myocardial function. So in short, you have to reduce the afterload now. How do you reduce the afterload? You use ACE inhibitors, angiotensin receptor blockers, beta blockers, vasodilators. So for ACE inhibitors, you can use enalapril. Okay, if maybe the patient complains of a cough, you can even change, maybe go to ARBs. But usually patients, we put them on a beta blocker, specifically carvedilol. Okay, carvedilol. So just to again to drop in the comment section why we give carvedilol in patients with heart failure. Okay, it's a beta blocker. Here we have said prevent decrease in myocardial function. So specifically it reduces the afterload. So the question is how. Okay, that is the question. So how does it reduce the afterload? What is the physiology behind this? Okay, we have to bear in mind the class of drug that it is, the beta blocker, then the pathophysiology of heart failure also, then you combine the drug and the pathophysiology, trying to find out why beta blockers, why carvedilol. Okay, then even vasodilators can be used. So that is specifically how you go about the principles of management of heart failure. Okay, so let's just do a summary. So 1 is general measures, 2 is reduce the preload, 3 is improve myocardial contractility, 4 is reduce the afterload. Okay, so what advice are you going to give to this patient? So the advice is to quit smoking and limit alcohol consumption. You have to follow a low sodium diet to manage fluid retention, regular exercise within the limits of tolerance, monitor blood pressure regularly and take prescribed medications consistently without stopping. Okay, and regular follow-ups. Then have to seek medical help promptly if symptoms worsen or new symptoms develop. Then for the diet, there's what we call as the DASH eating plan. Okay, so the DASH eating plan, this is for hypertensive. The people who are hypertensive, the diet that they should be following. So the benefit of the DASH eating plan is that it lowers the blood pressure and there will be a reduction in LDL, which is the bad cholesterol. So you tell patients to limit eating fat meats, full fat dairy, sugar sweetened beverages such as Coca-Cola, Fanta, and other sweet sugar fattened beverages. Then you also limit sweets, also limit sodium intake. Then what should they eat now? So they should be eating vegetables, fruits, all grain, fat-free, low dairy, low-fat dairy, yeah. Then fish as well, then poultry, beans, nuts and seeds. Then they should be using vegetable oil. So if there is no vegetable oil, then if they are cooking fish, they can just even not necessarily use the other oil. They can even just roast it. Okay, that is how you how you tell them. Then even they should even reduce the salt intake, okay, which has been discussed already. So this is the dash eating plan. Okay, then for question 8, a 34-year-old female is brought into the emergency department with history of having taken an insecticide after a local dispute with her husband 4 hours ago. She then presents with history of vomiting, drooling, and confusion. On examination, she has pinpoint pupils, underscored extremities. Vital signs are 86/54 milligrams millimeters of mercury, pulse rate 44 bpm, respiratory rate 14 breath per minute, temperature of 34.8 degrees Celsius. What other signs and symptoms will you elicit from the history and examination? Then what is the full diagnosis? Then discuss the pathophysiology of the diagnosis in part B. Then how will you investigate this patient? Then outline the principles of management for this condition, 6 marks. Okay, so that is the question I've been given. So what other signs are you going to list from this person who has come with who is a 34 male who has come with who has been brought into the emergency department with history of having taken an insecticide after a local dispute with her husband 4 hours ago? Then the patient developed a history of vomiting, drooling, and confusion. In an examination, she had pinpoint pupils and had cold extremities, vital signs of 86/54, pulse rate 44 beats per minute, respiratory rate 14 breaths per minute, temperature of 34.8. So the other signs you can do, you have the muscarinic symptoms or signs that you can elicit using the mnemonic / BBM or dumbbells. So there will be salivation, lacrimation, urination, defecation, emesis, bronchoria, bronchospasms, or bradycardia, that is from the sludge BBM. And for the dumbbells, this is just the same muscarinic symptoms or signs. It can be defecation, urination, meiosis, so meiosis, or bronchoria, bronchospasms, or bradycardia, emesis, lacrimation, salivation. That is the muscarinic symptom that you might elicit. Then for the nicotinic symptoms or signs, there is a mnemonic, which is Monday, Tuesday, Wednesday, Thursday, Friday. The MTWTF, which is muscle cramps, tachycardia, weakness, twitching, muscle fasciculations. These are the nicotinic symptoms you might want to elicit from the patient. So just remember we have the muscarinic and the nicotinic. Then what is the full working diagnosis? So the full working diagnosis is organ-phosphate poisoning. But if you want to write a comprehensive diagnosis, you can say the patient is having a shock, as you can see, and they have been vomiting. Okay, so you can say hypovolemic shock or hypovolemic shock, secondary to OPP. So meaning you have identified a major problem, which is the hypovolemic shock that you have to get rid of. Apart from that, the patient is also, why did the hypovolemic shock come from? It came from the OPP. So this is also another way of writing the full diagnosis. So hypovolemic shock secondary to organophosphate poisoning. That is how we go about writing a comprehensive diagnosis. You identify what the patient has presented with, what the patient has come with. Hypovolemic shock secondary to OPP. Okay, then discuss the pathophysiology. So organophosphate poisoning occurs when organophosphates compounds inhibit acetylcholinesterase enzyme, leading to accumulation of acetylcholine at nerve synapses and neuromuscular junctions. So this will result in overstimulation of cholinergic receptors, causing symptoms like the ones we've talked about, the muscarinic and the nicotinic receptor. That is the pathophysiology of how OPP bring about the symptoms. So in terms of investigations, we can do our labs. So we can do our red blood cell and plasma cholinesterase levels. So meaning there is what we call the red blood cell cholinesterase levels, and we have the plasma cholinesterase levels. These are our number 1 and number 2 investigations. And in 3, you can do other toxicology, U&Ds, creatinine, full blood count, random blood sugar analysis. For imaging, you can do chest X-ray, CT scan, echo, or ECG, depending on how the pictures come with. Okay, like I said, if they were to say give rationales, remember to give rationales on investigations in internal medicine. Okay, that's if they tell you to give rationales. Then outline the principles of management of this condition. Of course, you have to decontaminate. So in short, you have to do a protective gown, remove cloth, irrigate, then stabilize using the ABC, D and E. So meaning the airway, check if the airway is patent, and if there is any the patient said was drooling and so suctioning, so we can even suction the airway so that but when suctioning, just make sure you're suctioning what you are seeing. You want to, in case whatever you are seeing is done, you even start to go and suction things you are not seeing. Okay, so after that, for breathing, if the patient is having the respiration of like 44, so meaning you can even put them on auto. Then circulation, their blood pressure which is in hypotension. Then you can do a IV access line. You put your, so for the fluid now, this is where you be careful, because you don't want again to overload this patient and cause further even pulmonary edema. So where you overload the fluid on the patient already they're having bronchoria and extreme salivation. So it's like you'll be adding injury to the patient already. So okay, so before you even instigate that, before you have to take note of the treatment, which is atropine. So atropine is a competitive muscarinic inhibitor. So the dosage you can use is 0.05 milligrams per kg. For that is if you're using peds, but for adults usually we use 2 to 5 milligrams IV for adults. So that's how you go about it. Then you have to titrate to clearing of respiratory secretions. So like I said, you giving fluids without restrictions will end up causing more respiratory secretions. Okay, we end up causing more damage without adding something to treat the respiratory secretions. So if you are giving a fluid, at least you have noticed to say I've given the treatment to the patient. Okay, so we have to titrate to clearing the respiratory secretions and bronchoconstriction, e.g. So let's say you give someone, an adult comes, then you give them 2 milligrams IV. Then after 10 to 20 minutes, you have to check for vital signs, pupils and mouth for zen secretions. If still not improved or not yet reached atropinization, you can double the dose. Again, double the dose. So it's supposed to be the dose. You can double the dose here. So after you double the dose, so if you started with 2, you go to 4. After 10 to 20 minutes, still not improved. 8, still not improved. 16, not improved. 32, until they reach full atropinization. That's how you go about it. Okay, then also about what other treatment can you give with what we call pyridoxime. So pyridoxime is an oxime which has both muscarinic and nicotinic. So it has both muscarinic and nicotinic inhibitor effects. So it is a both muscarinic and nicotinic inhibitor. Then you give it 30 milligrams per kg. Adults usually a lower dose. Then peds a high dose. Okay, that's how you go about it. So specifically we are done on the question 8. That's how we go about the principles of management for the patient. Okay. Then question 9. Then remember that after you give them atropine, they will be in need of putting them on a maintenance atropine. So like I said, if you're giving them a fluid, at least you have to put a maintenance of atropine in that fluid to prevent the patient going back into the effects of OPP. Okay, because there are some organophosphate substances that like to hide in fats, and after they add in the fats, then after you have given your atropinization, then if the patient is not on a maintenance of about 20 to 50% of the atropinization dosage, then they might go back into the OPP effects. So that's why, so on the fluids you can only put, at least if the patient has reached atropinization, then after you put the fluid, then also add the maintenance dose of atropine. Okay, but if pyridoxine is present, then you know that it is this is the antidote here. So pyridoxine is the antidote, to be specific. It's the antidote. Okay, then question 9, it is saying outline the causes of lymphadenopathy. So causes of lymphadenopathy, we have infectious and non-infectious causes. So for infectious causes, we have viral causes such as Epstein-Barr virus, CMV, supposed to be CMV, varicella, roseola, infantum, adenovirus, HIV, rubella, measles. Then for bacterial, we can have typhoid, TB, syphilis, plague, infective endocarditis, AIDS, and AIDS-related complex. Then for parasites, we can have toxoplasma. Then for fungal, we can have coccidioidomycosis. Those are the infectious causes. Then for the non-infectious, we can have malignancies such as leukemia. And then the most common leukemia is acute lymphoblastic leukemia, which has 2/3 of all leukemias. Then acute myeloid leukemia is 1/3 of all causes of the leukemia lymphadenopathy. Then we have Hodgkin's disease, which is 1/3 of all causes of lymphadenopathy. Then for non-Hodgkin's lymphoma, it's about 10%. Okay. Then we can also have storage diseases such as Niemann-Pick disease, Gaucher's disease. These are the storage diseases. Then for metabolic diseases, we can have hyperthyroidism and lipoidosis. Okay. These are the causes under metabolic. Then under autoimmune and inflammatory disorders, we can have Langer and cells histiocytosis, we can have systemic lupus erythematosus, we can have Still's disease, we can have sarcoidosis, we can have serum sickness, we can have vasculitis, rheumatoid arthritis, and phenytoin toxicity. So these are the infectious causes. Then the addition on question 9 is that the ones which causes localized adenopathy, you can do a throat swab, urethral, cervical swab, blood culture, biopsy, and abdominal CT. If at all they are localized in there, you can even do if at all they are localized adenopathies. Then for the generalized adenopathy, you can do an erythrophile test, VDRL, antibody titers of viruses, fungi, toxoplasmosis, antinuclear antibodies, rheumatoid factor. Then for the IRA adenopathy, you can do a Mantox test, a chest X-ray, CT scan, S enzyme determination, bronchoscopy, mediastinoscopy. So these are the specific investigations for specific adenopathy if they are localized, generalized, or ILA. Okay, then for the last question, which is question 10, it says outline the symptoms, risk factors, and Duke's criteria for infective endocarditis. So answer is that signs and symptoms, we have the mnemonic from Jen. That is the mnemonic from Jen. So F is fever, growth spots, ozranodes, murmur, genuine lesions, anemia, neo-bed hemorrhages or sprinter hemorrhages. Then you can have emboli. So fever, erythroid spots, ozranodes, mama, genuine lesions, anemia, nail-bed hemorrhages, splinter hemorrhages, and emboli. That's from gene. Okay. Then for the risk factors, you can have prosthetic valve, you can have congenital heart disease, you can have rheumatic heart disease, you can have IV drug abuse. Those are the risk factors. Then for the Duke's criteria, we have the mnemonic B fever. So B fever, so B, this is a major criteria. Then fever with a double E, that's the Duke's criteria. And for the major, so B is blood culture, which is positive for 2 times 12 hours apart. So the blood culture should be positive at least 2 times and 12 hours apart. Then E is endocardial involvement from echo. Then for the minor, you can have fever, echo finding not meeting major criteria, so meaning the echo finding has not met the major criteria. Then V, vascular phenomena. E, so the double is for the evidence of microbial and evidence of immunological evidence. So that's talking about the erythroid spots, ozranodes, and glomerulonephritis. Then these factors for infective enteritis, that is a valve disease, IV drug abuse, etc. Okay, then so we have to now go in details of if you are told to go in details and explain the Duke's criteria. So this is how we explain it. So for the blood culture, you say it should be positive for more than 2 times apart. Then how do you explain that? So you say there should be a positive blood culture for typical endocarditis from 2 separate blood cultures or persistent. Okay, then for the endocardial involvement from echo, so you get a positive echocardiogram, which is a definitive vegetation or oscillating intracardial mass on valve or supporting structures. So in short, there should be a positive definitive vegetation, or there should be an abscess, a new partial dehiscence of prosthetic valve, or new valve eradication, increase or change in pre-existing mama, not sufficient for us to put it under the endocardial involvement from echo. So at least these other ones we have discussed are the positive endocardial involvement. Okay. Then for the minor criteria, we have fever. So the fever should be greater than 38 degrees Celsius. Then for the echo finding not meeting major, so meaning the echocardiogram finding is consistent, but so the echocardiogram is consistent with infective endocarditis, but not meeting major criteria. So meaning it hasn't reached the definitive vegetation and other things we talked about here and here. So, but the echo finding is positive for other abnormalities. In short, the other abnormalities that we have not talked about. Okay. Then for the valvular phenomenon, which is also known as the embolic phenomenon. So examples, we have major artery emboli, genuine lesions, septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhages. These are the valvular phenomenon, which is also known as the embolic phenomenon. Then you can also have evidence from mycobacteria, so microbiology. So evidence from microbiology, we talk about the positive blood culture, which is not meeting major criteria. For example, when someone gets one positive culture instead of more than 2 or more than 2 times, that is a minor, since it hasn't met the major criteria. So that's evidence from microbiology. Then E is evidence from immunological phenomenon. So examples, immunological phenomenon, we have ozranodes, erythroid spots, glomerulonephritis, rheumatoid factor. These are the immunological phenomenon. Then lastly, when someone has risk factors for infective endocarditis, the valvular disease such as the rheumatic heart disease, congenital heart disease, and of course IV drug abuse and prosthetic valves. So this is the major criteria when explained in details. Okay. Then how do you go about defining in the infective endocarditis? So we have the diagnosis. Sorry. So the diagnosis, we have the definitive diagnosis, the possible diagnosis, and the rejected one. So a definitive, we have the pathological criteria, where one, the microorganisms demonstrated by culture or histology in a vegetation, or in a vegetation that has embolized, or in an intracardial abscess. So this is when the microorganisms are demonstrated. Then you can also have a pathological lesion, so meaning where the vegetation or intracardial abscess is present, and it is confirmed by histology showing active endocarditis. So this is a pathological criteria. Then for the clinical criteria, which is the one we most commonly use, so it's a clinical criteria using specific definitions. So the ones we are from talking about, the blood culture, the echo findings from the endocardial involvement from echo findings, then the other fever and whatnot. So if you get two major criteria, so I mean you get the blood culture, which is positive for 2 times at different intervals 2 hours apart, more than 2 times, then if you get a endocardial involvement from echo, that is a clinical criteria, that's a definitive diagnosis. Then, or if you get one major and 3 minor criteria, so you get one major, you either get from the mnemonic you get the B or the E major criteria in one. Then from the FEVEER, if you get three of those minor criteria, then you have made the clinical diagnosis. That's the clinical criteria. Okay, from the clinical criteria. Or if the patient doesn't have any major, they should have 5 minor criteria for it to say they have infective endocarditis. Okay, then that is for a definitive diagnosis. For a possible diagnosis, this is when you have findings that are consistent with infective endocarditis that fall short of definite but not rejected. So in short, it's not like we are going to reject, just that it is a possible diagnosis. So it doesn't meet the definitive criteria. Okay, it's not pathological, it's not clinical as well. Then for the rejective criteria, or for the rejected diagnosis, this is where we have a firm alternative diagnosis for manifestation of endocarditis. Okay, so let's say someone who is a non-rheumatic heart disease patient comes to you and presents with signs of a pneumonia, but when you look at if maybe they have infective endocarditis, find that actually it's just pointing toward the pneumonia, then that's a firm alternative diagnosis for a possible infective endocarditis, for a rejected infective endocarditis. So it's like you have made a diagnosis that is a firm and it is alternative to infective endocarditis. Okay, so apart from an example that I gave, there can also be other conditions. Maybe they just have a myocarditis. Okay, then you are certain to say this is a myocarditis. Okay, that's one. Then two, can have a resolution of manifestation of endocarditis with antibiotic therapy for 4 days or less. So of course, if it's infective endocarditis, then of course they have to be more than 5 days on antibiotics. So if they resolve within 4 days, and if you made a definitive diagnosis, you have to reject the diagnosis if they resolve within 4 days or less. Then the last rejection criteria is when there is no pathological evidence of infective endocarditis at surgery or autopsy, or after antibiotics therapy for 4 days or less. That is the infective endocarditis definitive, possible and rejected criteria. Okay, so that's basically the end of the episode 1. So we'll be making even episode 2 with time that is coming forward. So we'll be making episode 2. So episode 2 also we will have episode 2 part 1 and the part 2, where we'll go from 1 to 5 questions, then from 6 to 10 questions. So thank you for watching up to this far, and please give us a like, give us a comment, and also make sure you even participate by giving us answers on the questions we were asking. Okay, and if you haven't subscribed, please subscribe and hit the bell notification, and of course see you on the next tutorial. If you haven't checked out the other the other episodes. You can check them out. Okay, thank you for watching. See you in the next tutorial.